Everybody, we are coming to the first topic over here is the saliva. And you know that saliva, obviously, as the name suggests, it's getting secreted from the salivary glands. Can anybody of you tell me the name of the salivary glands? It's very common, very parotid, submandibular, sublingual. Anything else? There are also minor salivary glands. These three are major salivary glands. Jegulo mostly 90% or 95% of overall saliva secretion that comes from the salivary glands. And salivary glands, there are major salivary glands, there are minor salivary glands. Major salivary glands are these three. One is the parotid, which is here, then submaxillary or submandibular. Same group, submaxillary or submandibular, দুটো আলাদা group নয়। সেটা রয়েছে submaxillary triangle, inner lower jaw. And the third one is the sublingual, under the tongue, beneath the tongue. That's three. Apart from that, we have buccal glands, we have lingual glands. এরকম বেশ কিছু gland রয়েছে which are minor salivary glands. এবার ছোট ছোট কয়েকটা জিনিস, there are a lot of things written in the book. তোমাদের সবটা জানার দরকার নেই. Just for your MBBS যেটা required, I'm just giving you something. So just write down salivary glands. Very quickly we will enumerate the salivary glands, kind of questions will come basically. Jeta question e lagbe. During your MBBS it's very important to know what to know and more important to know what not to know. Boigulote, that's very, very important. You will feel the importance as the year will pass by. At the end you will be having so many information that your processor will be slow. Just like the computer. So just get the most important, relevant, clinically relevant information. That's very important right from the beginning. So boiye prothom jodi ei page gulo kholo, first 2 pages what is written, that is actually equivalent to NCERT books. Ekhon ar tomader oi jinishgulo dorkar nei. Ekhon ar tomader oi jinishgulo dorkar nei basically. Okay, so first parotid gland. Just few points I will be mentioning. So parotid glands. Karo mone ache ki duct, parotid Stensen's duct. So parotid gland secretes 20 to 25% of total salivary burden. It secretes 20 to 25% of total salivary burden. So jar total saliva sara dine beroy, that is close to 1 liter to 1.5 liter per 24 hours. Er moddhe 20% is done by the parotid gland basically. And the duct is the Stensen's duct. Duct gulo MCQ হিসেবে আসে. So you need to remember, duct is a Stensen's duct and it opens up in a specific position opposite to second molar basically. So it opens up in the oral cavity opposite to second molar tooth, second মোলারটা কি ধরনের টুথ হয়? গুড, এগুলো তো জানার কথা, আগে থেকেই জানার কথা বেসিক্যালি। সো সেকেন্ড মোলার টুথ। তো তোমাদের এর মধ্যে ইম্পর্টেন্ট স্ট্রাকচার যেটা অ্যানাটমি ছাড়া যেগুলো জিজ্ঞেস করতে পারে, কত পার্সেন্ট সালাইভার বার্ডেন ইট ইজ টেকিং কেয়ার অফ, অ্যান্ড দ্য ডাক্ট নেম অ্যান্ড ওয়্যার এক্স্যাক্টলি ইট ইজ বিং ওপেন টু। দ্যাটস ইট। Okay, next is submandibular gland. Submandibular gland. Duct karo mone ache? Waters. Yeah. So submandibular gland kothay royeche? Inner side of the lower jaw. Submandibular gland that is present in the inner side of the lower jaw. Duct name Wharton's duct. Wharton. Wharton's duct. Eta apostrophe s last e jog korte hobe. So duct name is Wharton's duct. 70% of total saliva is secreted by submandibular. So tomader MCQ they might ask you which salivary gland secretes the most. That is this one, submandibular. Okay, so information যেটুকু মাথায় রাখার রয়েছে হচ্ছে লোয়ার জ ইনার সাইড, Wharton's duct, 70% of saliva. এইটুকু মাথায় রাখলেই চলবে। There are a lot of information given. তোমাদের অ্যাকচুয়াল ইনফরমেশন একটু পর থেকে শুরু হবে, which is actually required. Then এরপরে চলে আসছি সাবলিঙ্গুয়াল। sublingual, that's the smallest salivary gland basically যদি মেজর গুলোর মধ্যে দেখি, and ডাক্টের নাম রিভিনাস, so sublingual রিভিনাস ডাক্ট। অকেশনালি কিছু ক্ষেত্রে অ্যাক্সেসরি একটা ডাক্ট থাকে সাবলিঙ্গুয়ালে, এনিবডি? অনেক সময় থাকে, সব সময় থাকে না। অ্যাক্সেসরি ডাক্ট একটা থাকছে, অ্যান্টেরিয়র পার্ট অফ দ্য, অকেশনালি অ্যান্টেরিয়র পার্ট অফ দি সাবলিঙ্গুয়াল গ্ল্যান্ড ক্যারিজ ওয়ান ডাক্ট, যেটা নাম হচ্ছে বার্থোলিনস ডাক্ট। অকেশনালি থাকতে পারে। এগেইন দিস আর অল জেনারেল নলেজ কাইন্ড অফ আ কোশ্চেন, নট মাচ অফ হেল্প from the clinical aspect of the thing. So that is the Bartholin's duct. Occasionally accessory gland, accessory duct ekta thake. And the amount of saliva it secretes, it's koto? 5 to 10. 5 to 10%, more or less. Amount of saliva, or the volume of saliva that it secretes is 5 to 10. So that's almost the whole thing. Now my query to you will be, eta tomra already jano, what is acini salivary gland er khetre? Acinus, acini is the plural, acinus. So that's the secretory unit basically. So acinus, just egulo acinus or alveolus bole ekta kotha hoy ekhane. So acinus in case of salivary gland is the secretory unit of the salivary gland basically. Either ekta racemose structure hoy salivary gland er, and these you will be reading in a much better detail in histology. আমাদের অ্যানাটমির মধ্যে হিস্টোলজি হবে, ওইটাতে কি আমরা আজকে সময় নষ্ট করব না। সো দ্যাটস দ্য থিং, অ্যাসিনাস সম্পর্কে বা এই জিনিসগুলো ইউ উইল বি লার্নিং ইন দ্যাট। নাও আমাদের এরপরে চলে আসছি দ্য নার্ভ সাপ্লাই অফ স্যালাইভারি গ্ল্যান্ড, দ্যাটস ভেরি ইম্পর্টেন্ট, নার্ভ সাপ্লাই। বিফোর দ্যাট আই জাস্ট ওয়ান্ট টু নো তোমাদের কতটা আইডিয়া আছে অ্যাবাউট হোয়াট আর দ্য ডিভিশনস অফ নার্ভাস সিস্টেম। সেন্সরি নার্ভাস সিস্টেম কি আছে সিএনএস এ? সিএনএস সেন্ট্রাল নার্ভাস সিস্টেম কি আছে তার মধ্যে? ব্রেন আছে, স্পাইনাল কর্ড আছে। পেরিফেরাল নার্ভাস সিস্টেম তার মধ্যে কি আছে? সো দ্যাট দ্য নার্ভাস সিস্টেম দ্যাট সাপ্লাইজ দ্য পেরিফেরি। এন্ড দ্য থার্ড টাইপ ইজ অটোনমিক নার্ভাস সিস্টেম। অটোনমিক নার্ভাস সিস্টেম, দেয়ার আর টু ডিভিশনস টু অটোনমিক নার্ভাস সিস্টেম, sympathetic, parasympathetic. So what are the functions of sympathetic? হার্ট রেট কি করে? সিক্রিশন কি করে? জিআই সিক্রিশন। ভেরিয়েবল আছে, ওভারঅল কমায় বাট ভেরিয়েবল আছে, উই উইল ডিসকাস। ব্লাডার টোন অর তোমার ইউরিন এন্ড স্টুল সেটা কি করবে? হোল্ড করবে না ডিফিকেশনে সাহায্য করবে? হোল্ড করবে, ভেরি গুড। হোয়াট ইট উইল ডু টু পেরিফেরাল মাসল সিম্প্যাথেটিক সিস্টেম? পেরিফেরাল ব্লাড ভেসেলস তাতে কি করবে? কনস্ট্রিক্ট করবে। তাহলে তুমি দৌড়াবে কি করে? It's a fight or flight situation. You have to fight. You have to fight either with your legs or either with your hands. So you need more blood supply to your peripheral muscles. So central vasoconstriction, peripheral vasodilation. চোখে কি করবে? What it will do to your pupil? Dilation. So that more light can fall onto your retina, so that you can see more, kind of that. So that's the whole sympathetic supply. Now এখানে আমরা একদম point to point sympathetic supply চলে আসছি. We are coming to sympathetic supply. Sympathetic supply is T1 to T4. Sympathetic supply এটা হচ্ছে T1 to T4. Salivary glands, sympathetic supply. T1 to T4. T1 T4 কি? Segment, thoracic segment. So T1 to T4 কোথা থেকে আসছে? It is coming from superior cervical ganglion. It is coming from superior cervical ganglion. এই জায়গাগুলো অ্যানাটমিতে you will be learning much more detail way. Superior মানে you know that is above, cervical, CERVICAL, cervical ganglion. Superior cervical ganglion, তার post ganglionic fibers are the secretomotor fibers. Post ganglionic fibers মানে ganglioনের পর থেকে, after the ganglion the fibers যেটা যাচ্ছে next order neuron, those are the secretomotor fibers. তাহলে ওরা গিয়ে they are innervating the salivary gland and they are stimulating the salivary gland to increase the secretion, saliva secretion. The point to remember, One is T1 to T4, the second is postganglionic fibers from superior cervical ganglion. This is the sympathetic supply. আমরা আরো আসবো এর মধ্যে, just first know the basics. এরপর we will be coming to the neurotransmitters that is released from here. In a short while we are coming. Next is parasympathetic fibers. Parasympathetic fibers. It is coming from salivary nucleus. Salivary nucleus, brain আছে, brain stem. It is coming from salivary nucleus. Parasympathetic supply is coming from salivary nucleus. Remember one thing, the sympathetic system increases the mucus part of the salivary secretion. Sympathetic system increases the mucus part of the salivary secretion, whereas parasympathetic system increases the watery part of the salivary system. Overall, very quick summary, superior cervical ganglion, T1 to T4, mucus secretion increased by sympathetic system. Salivary nucleus supplying the salivary glands, there is the parasympathetic supply, it increases the watery supply of the salivary secretion. Clear everybody? Now we are moving to the next part, which is a little difficult তোমাদের জন্য মনে হতে পারে কি করে কাজ করছে। আচ্ছা তোমাদের do you have any idea about second messenger? You have idea. Second messenger you have idea. Can you name some second messenger? IP3 DHP. Have you heard of it? Can you have you heard of it? Since you already know about second messenger, it will be easy to understand. I will be just drawing a flow chart how sympathetic system acts. So coming to the sympathetic system, nerve already know these are the beta receptor which acts. Now beta receptors are stimulated when sympathetic systems are stimulated. Now this acts to the second messenger, which is adenylyl synthase, and ultimately they stimulate or they synthesize cyclic AMP. Once this cyclic AMP is secreted, and who is the neurotransmitter over here? The neurotransmitter over here is norepinephrine. Neurotransmitter over here is norepinephrine, which is a catecholamine. তিনটে catecholamine আছে তো, epinephrine, norepinephrine, dopamine. So here the neurotransmitter is norepinephrine. It acts on the beta receptor and it ultimately synthesizes GAM. So what happens? Then that increases the calcium concentration basically. যখনই remember one thing in physiology, most of the time calcium is a physiologically tonic substance. যখনই কোথাও calcium is being, whenever calcium is being released, the level of reaction increases or speeds up. সব সময় মাথায় রাখবে। And in most of the cases calcium will lead to either further ATP secretion or further phosphorylation and activation of enzyme. These things will keep on happening. So অনেকগুলো রিঅ্যাকশন রয়েছে যেখানে ক্যালসিয়াম ইজ ওয়ার্কিং। শুধু এখানে না, there are many places, আর কোন প্লেস মাথায় আছে যেখানে ক্যালসিয়াম কাজ করে and things happen? Muscle, heart, even memory that you remember things. Memory যেটা ধর চ্যানেলাইজ হচ্ছে, শর্ট টার্ম থেকে লং টার্ম মেমোরিতে কনভার্ট হচ্ছে, even there calcium is working. So calcium is working in bones, definitely in bones, in neuronal stability, membrane stability. Many places are there where calcium is extremely important. So CAMP is formed. Once the CAMP is formed, basically, one more thing you need to remember, not only beta pathway, also it can act on the alpha pathway. So we will remember that alpha and beta both it acts. Ultimately calcium increases and ultimately salivary secretion increases. What about the parasympathetic system? The parasympathetic system. So can you name one nerve which is parasympathetic in nature, very common nerve that is parasympathetic in nature? Hey, কি বলছো? প্যারাসিম্প্যাথেটিক একটা নার্ভের নাম বলো। হ্যাঁ, গ্লসোফ্যারিঞ্জিয়াল। ওকে, প্যারাসিম্প্যাথেটিক ভীষণ ইম্পর্টেন্ট। ভেগাস, মেন যেটা থাকছে ভেগাস। ওকে, সো প্যারাসিম্প্যাথেটিকে হোয়াট ইজ দি নিউরোট্রান্সমিটার, যদি কেউ জিজ্ঞেস করে প্যারাসিম্প্যাথেটিক নিউরোট্রান্সমিটার, acetylcholine. Acetylcholine. So there is a pathway basically in parasympathetic. This is acetylcholine, which is activating the kinin system, that is activating the kallikrein, that is ultimately leading to the bradykinin, that leads to local vasodilation, that leads to increased watery secretion. That's the whole pathway. The pathway is much deeper, pathway is much more detailed, but for you at this point, this outline is sufficient. You will be asked in the exam, what is the neurotransmitter here? ACH, acetylcholine. At least this is expected from you in the exam. So that's the whole pathway you need to remember. See, parasympathetic nerve, glossopharyngeal is partly responsible, vagus is responsible definitely. So parasympathetic nerve, whenever it is stimulated, it actually there is one pathway called kininogen pathway. That pathway is being stimulated. So if kinin pathway that is activated, kallikrein is converted into bradykinin. Bradykinin is a vasodilatory thing. Try to understand. Suppose inside mouth there are multiple capillaries. Capillary, what does it contain? Capillary excitation. Blood. What does blood contain? Plasma. What is the main constituent of plasma? Water. Water. Vasodilation. If there is a vasodilation, what does that mean? Plasma content in the local zone is increased. As the plasma content in local zone is increased, what does that mean? Water content in organ is increased. Water যদি বেশি থাকে, capillary wall, the water will be found in the mouth. Basically, so overall, what will happen? Watery secretion inside mouth will go up. And who is responsible for that? Who is the, what is the locking mechanism over there? That is parasympathetic system. So parasympathetic system, acetylcholine release, this kininogen pathway is open, ultimately vasodilation in the local area leading to more saliva secretion, rather we can say that leading to more watery part of the saliva secretion. Clear? তাহলে এই দুটো পাথওয়ে দিয়ে কাজ হচ্ছে। এই পাথওয়েটা ইউজুয়ালি দ্য মিউকাস সিক্রেশনটাকে বাড়িয়ে দেয়, আর এই পাথওয়েটা watery secretion কে বাড়িয়ে দেয়। There are n number of different neurotransmitters which will come shortly. Now coming to the composition of saliva, এটা সব বইতে আছে, তাও আমি বলবো you write it down because you can expect this question to come in your examination as a 5-mark question. Also in your previous years, ছোটবেলায় যেখানে ক্লাস 10 12 এই কোশ্চেন বহুবার এসেছে, composition of saliva. But again here we need to know something extra. Okay, so composition of saliva, certain areas what we need to know. What is the overall whole day, what is the volume? 1 to 1.5 liter per 24 hours. You can write these points only. Saliva overall secretion in a day, normal secretion in a day is 1 to 1.5 liter every 24 hours. Okay. During meals, what do you feel? During meal salivary secretion increases or decreases? Increases. During sleep or rest, what do you feel? Increases or decreases? Decreases. Is there any time when salivary secretion is zero? No saliva in a normal person? No. So whole day, whether you are eating something or not, irrespective of that, there will be some secretion. Am I audible? Audible to all of you. So this is very important concept for you. And this secretion is known as basal secretion. Basal secretion that is not only limited to saliva. Basal secretion means whole day, irrespective of you take food or don't take food, irrespective of you sleep or don't sleep, irrespective of any external factor or not, some secretion, some function will always be. Similarly, kilogram basal, that is the same for the TSH, that is the same for the insulin, very important for that. এই জিনিসটাকে বলে basal insulin, that's the baseline. baseline value. Give it a factor or not, it will still be there. It is basal. Above the basal, on occasionally, whenever there is some increase in secretion, we call it pulse or bolus. We call it pulse or bolus. Pulse secretion. So whenever you are, suppose we are not eating at present, but still you can feel your mouth is moist. That is due to the presence. Suppose I am talking definitely leads to increase in saliva. It requires because to keep your tongue lubricated. If you are not talking, if you are just sitting over there, your salivary secretion will be low. If you are, it's a factor. Speaking is a factor. Shouting is a factor. Definitely it's a less factor than feeding, but definitely it's a factor. So with some factor, there will be increase in salivary secretion. Not only saliva, it is true about all the fluids in our body. So this increase is known as pulse or basic bolus. Pulse or bolus. যখন আমরা একটা কিছু দিচ্ছি তারপরে এটা বেরিয়ে যাচ্ছে। Same happens with insulin, same happens with other hormones basically. Okay. Now coming to composition. Saliva main component is water. 99.5% water is present in saliva. Apart from that, what we have? We have solids. In solids, এইখান থেকে আমাদের ইম্পর্টেন্ট জায়গাটা তৈরি হচ্ছে। So saliva, water is the most important part, that is 99.5%. Apart from that, we have solids. Solids are of two types. One is inorganic solids, the other is organic solids. Inorganic solids, these are formed of ions. And what are the ions that is present? Definitely potassium, sodium, chloride, bicarbonate. These are the most important ions which are present over there. Other ions you can definitely get some magnesium, no harm. You might get some kind of iron, ferrous iron, you can get, no harm. But these are the major things which you need to remember. You can also get some calcium, you can also get some phosphate. These are important. Okay. Now, of which, what is more important? Suppose sodium is present approximately 100 milliequivalent per liter in saliva. Potassium is present approximately 8 to 20 milliequivalent per liter in saliva. You can also have this one cation. So this leads me to a little confused. And the second thing you might ask me, do we need to remember this? Do we need some? You don't need to remember the value of this, except only one. Look at the potassium concentration. How much is that? 8. What is the potassium concentration in plasma? And look at the sodium concentration. What is sodium? Less than 100? Less than 100? What is the sodium concentration in plasma? Huh? Sodium concentration কত প্লাজমায়? 137. আচ্ছা তুমি কাছাকাছি গেছো। Sodium concentration in plasma is usually 135 to 145 milliequivalent per liter. This is plasma sodium. And potassium concentration in 3.5 to 5. So important data from the point of view of, am I audible properly? But I don't think this is what. Hello. I'm just audible. This is basal audibility. Hello. এটা better. শোনা যাচ্ছে না? Okay. So তোমাদের যেটা এখানে দেখা, sodium, you are correct, 135 to 145. Potassium normally 3.5 to 5. What's the important thing? Why you mention this? Hyperkalemia or kalemia মানে blood. That is out of it. It's not. এটা তো saliva-তে হচ্ছে. It's not hyperkalemia. Important is you got the point properly, but couldn't articulate the word. Salivary potassium concentration is high. ভীষণ ইম্পর্টেন্ট এটা, কারণ তোমাদের পরীক্ষাতে আফটার এভরিথিং ইজ ফিনিশ দে উইল আস্ক ইউ ইন দি MCQ that following juice as the this particular gastric juice is having maximum potassium concentration, and they will give you some options like saliva, pancreatic juice, colonic juice, gastric juice. Saliva will not be the answer as of now, কারণ সবটা শেষ হলে আনসারটা বলে দেবো, but point to be noted that is saliva has a higher potassium concentration than plasma. এইটা কিন্তু খুব ইম্পর্টেন্ট একটা chromosome. So saliva has a higher potassium concentration than plasma. That's the inorganic part. Coming to the organic part, and in organic part there are so many things. Is the issue of organic part, if you remember, salivary amylase, we also have lingual lipase, we have immunoglobulin A, we have lactoferrin. These are immunological properties containing molecules. We have blood group substance, we have lysozyme, complete karo. We have lysozymes. Kallikrein already we have mentioned, you can write kallikrein. Bradykinin already we have mentioned, you can write bradykinin. I'm writing here. Kallikrein, bradykinin, already mentioned a while ago, so definitely they should be present in the saliva. You know, and each of them are having their specific function. Each of them. We are going to explain this. Salivary amylase, lingual lipase, IgA, lactoferrin, blood group substance, lysozyme. Mucin, that is also important. Mucin. Apart from that, many other substances important might be to some extent, very minute amount of urea, creatinine, uric acid we can find. You can just listen and write urea, creatinine, uric acid. This also we can find, but in trace amount basically. Major things which we need to discuss here, one is salivary amylase, lingual lipase. Then we need to discuss about the lactoferrin and IgA, how they work. Then kallikrein, bradykinin I have already discussed. Mucin, you know, that's the mucus part that creates the mucus part of the salivary enzyme. Now coming to the regulation, this is the next question. It's a question. So this is okay with all of you. Composition, it's a question. This answer is expected from you. This many things you need to just enumerate. It will come like enumerate the components of saliva. Similarly, enumerate the components of gastric juice. Enumerate the components of pancreatic juice. This will come. You will expect this question in the exam. Now this is done. Now we are going to the regulation of the salivary secretion, or how things actually get regulated, overall secretion. This is a picture of the secretion that we are getting. This is regulation of salivary secretion. Is it visible to you? continuous secretion, the other is reflexogenic or pulse secretion. In pulse secretion also there are two parts. One is conditioned reflex, the other is the unconditioned reflex or non-conditioned reflex. And I am going to explain. Okay, ready? Huh? So continuous secretion, this as I have already mentioned, this is the basal secretion. This happens overall 24 hours. It is irrespective of stimuli. Irrespective of stimuli. So if you have food, you don't have food, you are shouting, you are not shouting, you are inside a smoky room, you are not inside a smoky room, you are chewing now or not, it will be. How it happens? This happens because of continuous presence of minute means small amount of ACH from the local nerve endings. So continuous presence of ACH from the local nerve endings, that leads to this. So, pulse or reflexogenic, we are having conditioned and unconditioned. Unconditioned taki? Unconditioned reflex is suppose you are taking some food. Am I audible clearly? No echo, right? No echo. Okay. Suppose we are taking a food. Whenever we are taking a food, you will see there will be increased salivary secretion. Do you need to learn it as a child, as a baby? No. It is innate reflex. This is known as innate reflex. That is by birth you know. You are born as an alive creature, you know it. You don't have to learn it. পড়াশোনা এরকম হলে কত সুবিধা হতো। কিন্তু পড়াশোনাটা প্রবলেম হচ্ছে, that's a condition reflex. এইখানে প্রবলেমটা হয়ে যাচ্ছে। So we have to be like a dog, right? We have to work so hard. Like a dog we have to work to learn basically. Again coming back. So this is innate reflex. Stimuli is the presence of food or the taste receptors. So basically in the spatial senses, how many spatial senses do we have? Vision, olfaction, touch, taste, hearing. 5 special senses we do have. So out of these 5 special senses, direct sense to salivary secretion is the taste because it is there. It doesn't have to be learned. Innate reflex. Taste receptors are stimulated, leading to secretion of saliva. That is this. What is conditioned reflex? Conditioned reflex is something mild একটা ইকো আছে। এটা ইকো মাইল্ড। তোমাদের অসুবিধা হচ্ছে না তো ইকোতে? হচ্ছে না একটা ইকো, আমি পাচ্ছি একটা ইকো। অসুবিধা হচ্ছে না তো কিছু? ইটস ওকে। ছেড়ে দাও। Conditioned reflex, it is learned reflex. You have to learn. মাইক ছাড়া তো বলবো, কিন্তু তাতে আমাকে মাইক টাইসনের মতো চেষ্টা করতে হচ্ছে। ইটস ভেরি হেভি ওই অবধি পৌঁছানো। Condition reflex is something that we need to learn. Second is condition reflex is something where receptors are all except taste. Let us explain this. এটা কি অর্থ? Did you understand? Did you get it? Receptor যেগুলো হচ্ছে সেগুলো হতে পারে vision, সেগুলো হতে পারে olfaction, সেগুলো হতে পারে hearing, but taste. So condition reflexটা কি রকম? You are seeing a food, seeing a picture of food, you are smelling a food, you are thinking of food, and salivary secretion is increased. এইভাবে বহু মানুষের পরের দিন সকালে পেট খারাপ হয় because somebody else is activating their condition reflex. Clear? জানো তো অন্যের যদি খাবারের দিকে নজর দেওয়া হয় কি হয়, you know? So that's the pathway. সেটা হয় কিনা I am not sure. কিভাবে হয় that pathway I don't know, but this happens. Salivary secretion increases. How that happens? So what is the total pathway? Unconditioned এর একটা pathway আছে, conditioned এর একটা pathway আছে. I'm just writing that. If it is unconditioned reflex, food stimulus that is acting on the afferent nerves. এটাই তোমাদের লেখা। What are the afferent nerves over there? এটা ইকো আসছে, পারসিস্টেন্ট একটা ইকো বলা, ওগুলো একটাও কাজ করছে না। Acting on the afferent nerves, these afferent nerves are, hello, check, ever better. These afferent nerves are 9th, 5th, 10th. This is going to brain. Efferent is coming by 7th, 9th, 10th. Ultimately, it is increasing the salivary secretion. That's the whole pathway. It was unconditioned. Unconditioned. The thing to remember, in 9-10 গুলো কি cranial nerve. 9-10 যেগুলো লিখেছি এগুলো হচ্ছে cranial nerve. 5th nerveটা কি trigeminal. 9th কি glossopharyngeal. 10th কি vagus. এরা স্টেজ স্টিমুলাস যেই সুইচড অন হচ্ছে এরা নিয়ে যাচ্ছে ব্রেনে, ব্রেন থেকে আবার ইফারেন্ট ফিরছে। ইফারেন্ট কি ফেশিয়াল 9th and 10th, ফেশিয়াল হচ্ছে 7th, 9th, 10th, এরা ব্যাক করছে, ব্যাক করে স্যালাইভা সিক্রিশনটাকে বাড়িয়ে দিচ্ছে। দিস ইজ দি unconditioned reflex. Conditioned reflexe, you need to understand that there is a lot of abstract things are happening, lot of abstract things. মানে কি, you are thinking about a food, you are seeing a food and this is happening. That means other areas of brain is affected or is connected. So what are the other areas of brain that is connected in conditioned reflex? Along with this pathway, there is also forebrain, hypothalamus, and limbic system. These are the pathways which are, or these are the areas which are connected to the conditioned reflex. Conditioned reflex, for example, Pavlov's experiment. Pavlov's experiment, and Pavlov's experiment কি ছিল? There was a bell and there was some food. Basically the dog was there. Initially he used to give food to the dog. So the unconditioned reflex is intact, it is proven. Salivary secretion was measured basically. Also gastric secretion was also measured. That is the crueler further 2.0 version of the Pavlov's experiment actually. Okay, that was one. Then what happened? They started ringing a bell and giving a food. Ringing a bell and giving a food. So that creates the conditioned reflex. That is the learning for the dog. Now the dog knows whenever there is a ringing of bell, there will be food. So he is activating his unconditioned reflex to the sound of the bell. And after a few days, Pavlov became a politician. He just rang the bell, no food. Right? So we all become conditioned to good days or whatever. Anyway, so the dog also became conditioned to that. So ringing a bell, that leads to development. So dog's idea, like dog's hypothalamus, dog's limbic system, everything connected to it was being ignited by the auditory system, auditory stimulus. Ringing a bell is what? Auditory system. It's nothing ringing. You can't eat a bell, definitely. So that's the conditioned part of the reflex. Clear? Okay. I think we are almost at the last part. Pavlov's experiment is also something you can expect as a short note. Short note hoye Pavlov's aste pare. Conditioned reflex is also a short note, not totally limited to this discussion. It can be anywhere else. First paper, second paper, duto paper hi aste pare conditioned reflex, because this is very important physiological clue to many of us basically. Lastly, something called salivary secretion. It is called, adaptability of secretion. Something different headline. It is known as adaptability of secretion. What is adaptability of secretion? Salivary secretion fluctuates according to the food type. সেই জন্য তুমি if you take very spicy meal, definitely salivary secretion will shoot up. If you take ice cream, it will not shoot up that much. So it all depends to the type of the food, to the taste of the food, to the temperature, humidity, to the context of the or texture of the food, so many things are actually required. Very hard food jodi hoy in a dry system, tale hard food take to bhangbar jonno or to make it lubricated, you need more amount of saliva, and that is being secreted. So that's called adaptability. Jerokom proyojon sei bhabe you need to adapt. Depending on the need, salivary secretion either goes up or comes down. That is adaptability, and that happens in a neuronal level. So nerve guloi adapted hoye jay to the extent of the stimulus. Function of the saliva. Last discussion today. Very quickly we will be finishing up. Only points I will be mentioning, you can write and you can elaborate from your +2 knowledge basically. First is solvent. Saliva acts as a solvent. Second, saliva acts as a lubricant. You don't, I don't need to explain this. I think you can write. Saliva acts as a lubricant. What it lubricates? It lubricates the food. It helps in the grinding of the food basically. Movement of the mouth, teeth are grinding against each other, and it is keeping everything intact. That is by the salivary. This is an engine oil, kind of engine oil to the mouth basically. Third is, it helps as a, it acts as a protector. Kibabe protect korche saliva? Two things important. First of all, definitely wear and tear comes down. If the inside mouth is lubricated, wear and tear comes down. But two important specific thing you need to write. One is IgA and the second is lactoferrin. IgA is immunoglobulin A, which acts as a first line of defense against incoming bacteria or fungi or virus. Whatever we are eating, we are not eating sterile food. We are not eating sterile food, and other mammals, they are not even eating clean foods. Even after that, they can sustain their life. So there must be some defense mechanism all through. The first line of defense is the IgA over here. Je kono cavity te body te immunoglobulin A beroy, and this has, it can create antibody, it has its own immunological way. Lactoferrin is another substance that is present as an organic substance in saliva, and lactoferrin is antibacterial. Lactoferrin has antibacterial property. So again, lactoferrin, antibacterial property, definitely. So it can help like that. Salivary amylase or alpha amylase. So digestion part. So it breaks down boiled starch to limit dextran, if you can remember. So salivary, it breaks down the glycosidic linkage inside the starch actually. Salivary amylase or alpha amylase, or we call it ptyalin. So that breaks down the boiled starch into limit dextran. That means simpler molecule. It breaks the glycosidic bond between the complex structure, breaks it down, simpler structure is formed. Lingual lipase. Lingual lipase as the name suggests, so it breaks down lipid. Lingual lipase is something that breaks down lipid. There is no proteolytic enzyme under normal condition in our mouth, so proteolysis starts once food reaches the stomach, which we will be discussing on the next day. And lastly, there are certain things like the optimum pH of saliva should be 6.8. Optimum pH of saliva should be 6.8. And digestive enzymes in saliva are maximally activated when chloride ion is present. Digestive enzymes in saliva are maximally activated when chloride ions are present. So that is all for today. Salivary area, its regulation we have discussed, its composition we have discussed, and certain MCQs we have discussed. These are the things which will be asked in the examination. Regulation, nerve supply, condition reflex as a short note, overall regulation of salivary, condition, non-condition, and basal, you need to remember. Function of saliva that we have just now finished. Components of saliva, you can be asked in the examination. Enumeration of salivary glands, who all are they, and what is the sympathetic supply, what is the parasympathetic supply to the salivary glands. These might be asked as a sub-question to a long question. Understood? At a boro question er moddhe eta. However, since we have so many important topics in GI, salivary theke long question ashar chance ekটু কম. Short question and MCQ jonno get yourself prepared. Occasionally some explain why and clinical physiology. Next day we will discuss some part of the clinical physiology of saliva and major part of gastric juice. And this will continue. 4.2 will take up to 3 classes. PY 4.2 will take up to 3 classes. Okay, done?
started the genetics, and we moved couple of the topics related to the genetics, like the karyotyping, which could be an exam short note, the procedure of the karyotyping, which it could be your exam short note as well. So we have to know about these chromosomes, and we have to know about these particular classifications of the chromosome. And I was given with a bad battery. Yeah, it's moving now. So these principles of this peripheral blood leukocyte culture for procuring these chromosomes, it could be your exam short note. So if you are there in the class or not, doesn't matter. You just have to prepare this. Now from here we are going to talk about this particular topic related to this particular chromosomal errors. That's a topic we had a very few attendance. That's why I have to redo the contents and the topics, which is the errors of the chromosomes, which is of course clinical thing. And so here we are. This could be an exam short note, is chromosomal aberrations. So we are going to talk about the chromosomal errors that can be of two types. One is we have a particular species, and a particular species we have a fixed number of chromosomes. That means in a human species we have 46 chromosomes. Now that means 23 pairs. So either we may have the chromosomes excess or less in number. So that is considered as this particular thing, which is called as chromosomal aberration. Or the chromosomes which has a particular structures. That means it has two arms. We call them as short arm, we call them as long arm, and in between, joined in between by the centromere. So you may have a structural loss or gain in a chromosome long arm P arm. That could be also regarded as chromosomal aberrations. So in a summarily, we have two types of chromosomal error. One is numeric, that means the number error, or structure error, that means it is broken, fragmented, or joined, elongated, looks like different than that of chromosome, right? It should be a rod shaped. If it is not rod shaped, it could be circular. That means it's a chromosomal aberrations. So this is what we are going to talk today. Then we are going to talk about specific chromosomal errors, which is known as this numeric chromosomal errors, which may be involving with some kind of diseases, which is known as, commonly we have these three sets of diseases, which is known as Down syndrome, Turner, and the Klinefelter. So you have to know about the phenotypic feature, the genetic feature, and the clinical presentations of these particular individuals who are suffering with this. Now because this particular individual may have associated errors in the developmental organs as well. So when you move to the organ development in the embryo, you will come across that particular individual with chromosomal errors might have some kind of defects, maybe cardiac defect, maybe just kidney defect, maybe just like intestinal defects, etc., etc. So those things should be linked with each other whenever you are studying the thing, studying the disease as a whole, right? So this is the plan for the day. So we are going to talk about these aberrations, then we move to these particular diseases involving in this, and then we are going to talk about some phenomenon, we call them as like a mosaicism, chimera, and non-disjunction. That's a topic for covering today, and that covers this entire genetics. And I have mentioned that the genetics is in a domain of the biochem. So you are going to learn a large chunk of genetics and genetic disorders in biochem. For anatomy, we have a very small segments to cover, which I am covering, and presumably this is the last genetics lecture which will be covered. So this is what we are starting with, the chromosomal aberrations. We mentioned about two kinds of like a chromosomal error we have. One is the structural error. We'll discuss about the structural error, then move to the number error. So coming to this particular structure error. So we have this particular chromosome like a structure, which is maybe just like have kind of like a problem in the structures, maybe having a fragmented part which is deleted, we call them as deletion. Maybe just like it is a reversely joined, we call them as inversions. Maybe have an exchange between these particular chromosome groups, we call them as translocations. Maybe it looks different, we call them as the ring chromosome. Maybe have a abnormal separation, we call them as isochromosomes. That's what we are going to talk today. So first thing we talk about this chromosome aberration. This is the whole chart. That's what we are going to cover, the numeric and structural. We will focusing the structural first, then we move to the numeric error. Now this is what we are talking about, deletion. As the name implies, easy for us. It's a part of the chromosome is deleted. So, the deletion may be involving two ends, maybe involving this particular terminal parts of the chromosome, that means the fag end of these particular chromosome arms, we call them as terminal deletions. So, at the terminal end of the chromosome, terminal end of the P arm, terminal end of the Q arm, they may be deleted, we call them as terminal deletions. Or maybe it may be deleted at the middle of the chromosome, it breaks and it is deleted. So, that kind of deletions, if it is happening in the middle of the chromosome, we call them as intercalary deletions. So, it breaks in the two chromosomes, loss of the intermediate segments. So, two ends is broken, the middle fragment is lost or deleted, and then it is joined with the rest part, and it is the chromosome which looks like shorter than the rest of these things. Now, this particular middle deletions, which is known as the intercalary deletions, which is not very common, rather the terminal deletion, which is more common. And this particular terminal deletion leads to loss of the chromosome genetic material. And as a result of that, it can bring some diseases. One of these particular terminal deletions involving the chromosome number 5 that can bring a disease, we call them as Cry-Duchat syndrome, which is again in genetics in biochem, you are going to learn detail of this. So, this particular chromosome, which is deleted in a short arm of the chromosome number 5, can bring rise to this particular deletion. So, this is a chromosome which is number 5, and you can see the number, you can see this particular size of this chromosome which is there. This is long, more or less everything is present. This is the other isochromosome, which is the other one, other half, and we see that the length which is shorter. So, this particular measuring the length of this normal size with this particular corresponding size, we can come to a conclusion that we have a loss of chromosome, and this particular chromosome loss involving the 5th chromosome can bring in kind of diseases, which is known as this isochromosome diseases, which is known as the Cry-Duchat syndrome, which is in detail the clinical feature you are going to learn in biochem. Next entity of a chromosomal structural abnormality, we call them as translocation. That means the change of places. You are sitting here and they are sitting there, later little bit. You hold it, write it note, later on I will address. So, we have change of places. You people are sitting here, these people are sitting there, they are changing from this side to that side and that side to that side. So, there is a change of the place of the chromosomes or genetic material, we call them as translocations. Now, this particular translocation may be a balanced or may be unbalanced. That means 4 people moving from here, 4 people moving from there, switching the position. That means it is a balanced move. 6 people moving from here, 4 people moving from there and changing the places. That means it is an unbalanced to one side. So, it could be a balanced kind of exchange, which could be right hand side is equal to left hand side is equal to proved, or maybe right hand side more than left hand side or left hand side more than right hand side, switch off this particular genetic material. That kind of thing we call them as unbalanced. That means it is not equal the same amount of the genetic material which is exchanged, which is switching the position, right. So, this could be there. So, there are 2 varieties of these translocations are there. One of them we call them as Robertsonian translocation, which is of prime importance. We will know why this Robertsonian translocation is important. Other is we call them as reciprocal translocation. Now, what happens with the Robertsonian translocation? It's the entire arm of a chromosome which is switching the position. That means we have a short arm, we have a long arm, right? Involving this particular long arm and short arm, the short arm of the chromosomes of a particular group switches between them, changes between 5 to 6 or 6 to 5 or whatever it is. So, this kind of entire length of an arm entirely taking place in kind of this translocation, we call them as Robertsonian translocation. This is one variety. Other is we call them as reciprocal variety. That means a portions of the arm is broken, changing with the place with the other end. But mind it what I am saying, a portions of the arm and the translocation which is involving the Robertsonian entire arm. So, the picture thing which will clear these ideas about this particular translocation. You see this particular picture over here. We have the red dots and we have the blue dots. So, we have this particular chromosome number 14 and chromosome number 21. So, you just have a look at this particular chromosome number 14 blue and chromosome number 21 which is the red. Now, we have a long arm, we have a short arm. Now we see that the short arm of these two and these two, they are moved out, snapped out. And what happens over here? The long arm of this particular chromosome number blue and long arm of the chromosome number red, they join together and makes a new chromosome. And what happens to the small arms? They are fragmented out. So we have developed a new chromosome involving the long arms, both of these, chromosome number 21, chromosome number 14-1, which is a new chromosome, 14 by 21, which is the segment. And then we have this loss of segment of these particular small arms of chromosome number 14 and 21. These pieces are out and they are separate. So this kind of chromosomal translocation, which is particularly happening with these particular chromosomes, 14 and 21, between them, we call them as Robertsonian translocation by the discoverer, by the observer who mentioned about this particular disease. Now, this kind of translocation, if this particular individual is suffering from, we have examined that this person with this Robertsonian translocation developed a clinical or phenotypic resemblance of Down syndrome. So the person of the Down syndrome have this particular genetic error. And this kind of genetic error can bring a phenotypic diseases which is similar or like Down syndrome. So one of the causes of Down syndrome is we have one extra chromosome, which is 21 number, which is 3 in those individuals. Apart from that, in some of the individuals, there is no extra 21 chromosome. Rather, they have this particular Robertsonian translocation. So this is one of the cause of Down syndrome. That's why it has great clinical importance to us. Now, coming from this particular Robertsonian translocations, this is what we are talking about, reciprocal translocation. The reciprocal translocations could be of a balanced variety and non-balanced variety. That means reciprocal. I will give you money, you will give me some food or something like that. So there is a mutual trade happening between these two. Now, it could be balanced, it could be unbalanced. That's what we are talking about. So, the chromosomal exchange which is taking place in this particular individual, which is reciprocal translocation, is this one. So, see over here, this particular phenomenon we are looking at. So, this is blue chromosome, this is red chromosome. We have this particular long arm, this is the long arm. They have snapping and they have the mutual exchange between them. And they are bringing the blue and red and blue like this. So we have the exchange of material which is similar size chromosome with no loss of genetic material whatsoever. Compared to the lower number picture which you are seeing here. Again, this is involving this part, this is involving this part. And then we have this particular exchange which is taking place with this particular blue, this particular red is coming and this one is going there. And you see the length of this chromosome is different. So we have this particular chromosomal length which is increased or decreased, and as well as we have a disproportionate exchange of this particular genetic material. The amount of this particular length and this particular length is not similar. So we have this kind of exchange of the genetic material which is unbalanced variety. So this is a kind of thing which is happening between the translocations of this particular chromosome. We call them as reciprocal. That means both of them are participating, both of them are contributing to it, maybe in a similar manner, similar extent, or maybe dissimilar. Maybe have got like a little bit less or more like that. And resulting in a chromosome which is of different size and chromosome which could be of capabilities of having different synthesizing or protein synthesizing capabilities. So this is about this particular translocation or different types of translocations. The other types of aberrations, inversion, that means head down, leg up, or leg down, head up. The way it is inverted. We have a breakage of chromosome and then rejoining of the chromosome. Now this particular rejoining of the chromosome is happening in a reverse manner. It is flipping, giving a somersault and joining. This is how it is coming. So this particular picture may be clearing the idea about this inversion. See this. we have this A, B, C, D, E, F chromosome. Was there. Now we have a break over here and there. Now we have this particular thing develops into here. So see that after A we have the B, but over here after A we have the F. Where was the F? It was here. So it has broken on the segment, flipped, twisted and inversely joined with the A, and B have moved to the other tail end over here. This is known as inversion, inverted or reverse manner joining. It is happening on the same chromosome. It is not like happening to two different chromosomes. So only one single chromosome where this breakage is there involving in it, we have the break and rejoining as well, reassembling as well. But this reassembling is from the reverse manner. So this thing moved like this. So this is a mirror image which is created out here. Now, this particular inversion or rejoining can be divided of two types. Maybe this breaking and this rejoining involving with the centromere, or maybe not involving the centromere, only in the arm of a chromosome may be happening. So depending on the variety of the inversion which is taking place, whether it is involving with the centromere or not involving with the centromere, we divide this particular or classify this as inversion as pericentric involving the centromere or paracentric excluding the centromere. These are the two simple varieties. So this inversion, if it is taking place, this upper picture which you are seeing here, picture number A, which is involving the centromere, the black dot, and joining in the reverse manner. So this is a variety we call them as which centric? Pericentric, because it is involving the center, and this one is not involving with this black dot. That means it is paracentric. So these two varieties of the inversions is there. But the key is it is involving with the same chromosome. It is not that two other chromosomes is coming. It is a breakage of the same chromosome and rejoining of the same chromosome, but this rejoining is taking place in a reverse manner. See, not the straight way it is fitting in, cutting in and fitting in. Okay. Now, other variety of the chromosome error. Now, during cell divisions, we have this particular chromosome lined up in the central part or equator region of this particular cell, and then we have this particular string which is pulling and keeping this particular chromosome separated and moving to the different poles. So we have a breakage or separation of the chromosome taking place and moving apart to the different poles of the cell during the cell divisions or separation phase of the chromosomes. Now this particular separation of this particular chromosome happening to take place with the breakage of the centromere laterally. So we have a lateral split and then it is moving out. So if the split of the chromosome which is taking place, moving this particular thing away, instead of being a lateral split, if it is not happening with the lateral split, if it is a vertical split, then we have this particular error. So this particular chromosome, what happens? This is the normal thing which is happening over here. We have a lateral split of the centromere when it is separating. This part is going down, this part is moving up. This one is a small arm, this one is a long arm, and eventually after the separation we get this particular two chromosome which is of having same size more or less and have got P arm and Q arm, P arm and Q arm like this. So one arm short, one arm long, which is separated like this. So this is a normal thing which is happening between this separation time. Now, if this particular separation goes wrong, if this particular microspindle which is anchored is a long point or is a wrong point within the centromere, it can happen here that this particular separation can break like this, snap horizontally like this, and separates these two small arm separates from the long arm. So this two long arm moves to the side of the pole and this short arm moves to the opposite side of the pole. So this particular thing creates a chromosome which only has two short arms and two long arms. So this kind of chromosome, if it is only have long arms or only have short arms, we call this particular chromosome as isochromosome. So it is a split error which is taking place. Clear? So we have this particular split of this particular centromeres taking place in the different level, different types. So instead of this particular lateral separation, we have a transverse separation that leads to these particular formations of this isochromosome, which is nothing but only the P arms to the chromosomes, no Q arms, or only the Q arms, no P arms, whatever it is there to that side of the chromosome. So this is what happening with this isochromosome phenomenon. Coming to the ring chromosome, that's what you talked about. How do the chromosome look like? It's a rod-shaped structure, right? So it's a rod-shaped structure which has a long arm, short arm, P arm, Q arm, etc., etc. But by any chance, if the chromosome looks like ring, we call them as a ring chromosome. So how we can make a ring from the rod? So this thing happens over here, this particular chromosome which has this tail end of the chromosome, the P arm and the Q arm. So what happens with these particular diseases or errors, we have this particular long arm and the short arm of a particular chromosome, terminal end deletion happens here. So these two ends of this P arm and the Q arm is broken, fragmented and separated. That leads to this particular chromosome which is this particular end and this particular end open. And this particular broken end over P arm and the short arm, they are very sticky. So with the division, with the rolling of the chromosome, this particular two ends might come closer together and rejoin like this and give rise to this particular ring chromosome formation. This happens if the chromosome becomes extremely fragile. In case of the cancers or the person who is suffering from the increased metabolic divisions, the cancerous cells exhibit this kind of abnormal chromosome formation. Because of this particular fragile chromosome nature, it snaps or breaks to the other ends of these chromosomes and resulting in these ends which is known as sticky ends of the chromosome. These sticky ends joins with each other when this particular cell processing is going on and give rise to this particular ring chromosome. If you find any ring chromosome in a cell or in cellularity, this particular person is prone to have cancerous or abnormal metabolic diseases. So this is a thing which you have to know. The telomeric region, telomere end or tail end of the chromosome breaks and joins itself with it end to end and give rise to this particular circle thing which is known as ring chromosome. Now we are coming to this particular other end of this particular chromosome error which is known as numeric chromosomal abnormalities. Now we stop at this moment. Any doubts, any queries related to this particular structural chromosomal error, whatever you have? Yes, you can go ahead. Deleted part go. What happens to the deleted part? Okay, and what is the first question? How this, why this thing's deletion happens? Okay, all right. Now thing is that there are several, please, there are several reasons out there for having this kind of like deletions. So it could be exposure to some substances, like if you are exposed to some kind of like a rays that makes this particular cells and the chromosome vulnerable, weaker. It could be with the increased age, this chromosome itself like becomes fragile. It could be some familiar diseases where this particular chromosome structure itself is a weaker. And these particular things precedes with the time and exposure to this particular environment, exposure to the chemicals that leads to this kind of like vulnerability of breakage or deletions of the chromosomes. Now, if you have a breakage of these, a portions of the chromosome is separated out. We call them as fragmentations of the chromosomes. That particular fragments which is separated out, we call them as fragment ends, which could be small or large or maybe of abnormal sizes. Now, what happens with the fragmented ends? It could be absorbed itself by the cells or it would be absorbed by different chromosomes, sticking to other chromosomes, joining there and making an abnormal size length. Or itself, it could be destroyed or damaged by this particular process of this particular cell division as it is moving. So, it could be of various kind of like fates over there. So it could be rearrangement themselves with this particular fragmented end, which is possible, or maybe lost during this particular cell division process, which might have a loss of the genetic material during this particular. That's what we talked about a disease, which is known as Cry-du-Chat syndrome, which is involving the deletions of the 5th chromosome. We have a loss of the terminal end of the P chromosome, and this particular lost chromosome is usually we see sometimes present as a separated fragments, or sometimes we see that this particular entire length is absorbed or vanished because of this particular thing, which is maybe just like ripped off or kind of absorbed, or we have this particular lytic enzymes which is which is digesting those kind of things. All right. So from this structural error, we are moving to the numeric error, which is familiar to us to some extent. We call them as like a trisomies, Down syndrome. So we have a Down syndrome to address, we have a Turner syndrome to address, we have a Klinefelter syndrome to address about this particular structural chromosomal abnormality. So Down syndrome, which is quite familiar to us, like we know many things about this particular thing. So whenever you are given to this particular thing to address, we know this particular what is the genetic error to the individual. It is a kind of autosomal chromosomal error. So the autosomes which is having a trouble with this, we have a trisomy of the 21 chromosome, which is commonest variety of the causes of this Down syndrome. It could be of some reason which is known as a Robertsonian translocation. We mentioned about the translocation between the 14 and 21. That Robertsonian translocation can lead to the features of this particular Down syndrome. Other cause of this, it could be mosaicism. So we're going to talk about what is mosaicism in a later phase of this particular thing. Now, once we have this particular Down syndrome, which is quite high in incidence, if you are getting this particular like a birth rate, which is every 1100 live birth, we get a patient, we get an individual with this Down syndrome. Now, how do these particular persons look like? So, we have to know about this particular look-alike. We call them as phenotypic feature. So, physically, how do they look like? They have this particular growth which is stunted. So, they have a short stature, arms are short, fingers are short, digits are short. They have the facial characteristics which is broad, flat face. They have a rounded head. They have a typical fold in the eyes. We call them as epicanthal folds. And they have the tones of the muscle is really less. We call them as hypotonia. Many times if you see this particular person, you see their tongue is sticking out. So the reason of the tongue protruding out because of the poor tone of the tongue muscle. They are sticking out. They have a very problematic with this particular intelligence level, or they have the cognitive error. So they are analytical ability or cognitive ability is poor. We call them as mentally, they are kind of like not that at par with the stage. They are differently able people. They have a particular pattern in the fingers. So we have this particular fingers which has got particular pattern in our finger. We have a pattern of this particular skin. We call them as dermatoglyphic pattern. So they have a typical pattern of the Down syndrome. So we just like finger impressions, we can figure out this Down syndrome. So they classically look like the persons, they are usually like very low toned people. They look like this. They have a characteristic facial pattern. And they have this particular common error involving here is this trisomy of the 21 chromosome. The causes of this trisomy 21 chromosome is the disease we call them as non-disjunction. So why we have an extra pair of the chromosome? We call this particular problem with this non-disjunction. We have a translocation we talked about, and then we have the mosaicism, which is the cause of having this kind of error. So we'll talk about mosaicism very soon about it. So this is the like a Down syndrome which you have to just like narrate and describe about. Next we move to this particular other disease which is known as Turner syndrome. So this particular individual which is like involvement or absence of a sex chromosome which is involving the female persons, they have a loss of X chromosome and they are denoted as 45XO. So we have this particular 45 chromosome which is one less in number and one X is missing. We call them as also monosomy of the 21. They have this particular absence of bar body because only one single chromosome X is there. The causes of Turner syndrome is same thing. We have this particular like could be have this non-disjunction, which is separating this particular chromosome in an error. It could be there. It could be mosaicism. We'll talk about the mosaicism, what it is. It could be deletion of one entire chromosome. One X chromosome is completely deleted, maybe there. Because of that particular error, we may have this particular problem as well. Now, what's the problem with this particular thing, which is the Turner syndrome? They have this particular characteristic pattern or phenotypic error with this. So, there, the female individual who are suffering from this, they are having very poorly developed ovary. So, the ovary is missing. Many a times, this particular person who was suffering from this disease, but looking at it, you may not be just like able to figure it out, they have this particular disease. They come with this particular problem, we call them as amenorrhea. That means they are not having or started with the menstrual period. So, that particular person who have this particular absence of menstrual period, we call them as amenorrhea. We explore or try to find out why this particular disease is there. We find there is an absence of the ovary or poorly developed ovary. Now, this particular poor development ovary is, we call them as strict gonad. So, that can lead to the sterility and this particular poor environment error. Okay. Second thing is that they have the short stature, they have a waving of the neck. So, if you just look at this particular picture over here, so if you look at the particular picture, if you look at the neck over here in this region, this particular neck region, the skin over here is a little bit like projected or flattened or broadened. This particular neck we call them as the broad neck region. We call them as a waving of neck. This could be the one of the sign which this particular person phenotypically present. We call them as broad neck. They have this particular external female genital ears. They are poorly developed. Their sexual characteristics poorly developed, and they may have an association with these kidney diseases. We call them as horseshoe diseases, horseshoe-shaped kidney. So, we'll talk about these diseases, what is horseshoe-shaped kidney, when you develop developmental error of this chromosome is talking. Now, moving to this particular another disease, we call them as Klinefelter syndrome, which is this another disease which is involving here. We have this particular one extra X chromosome in the male subjects. So, if you have a chromosome which is 46 and if you have an extra X in the male subjects, we call this as an extra X chromosome. And this particular person who has this Klinefelter syndrome, it's this particular person, they have a particular pattern. So, this particular X chromosome having X, the male have that extra chromosome pair which is X is inactivated as a bar body. We have this particular bar bodies which is present in it. The Klinefelter syndrome, we have an extra X chromosome in the male individual. So, phenotypically they are male. So, this particular male have got like a problem with this having an extra X chromosome. So, this particular one extra chromosome which is rare, that means they have the 46 XXY, that means 2 X chromosome, and that one X chromosome has to go as a bar body. So, eventually these particular male persons who are phenotypically male, they have this particular bar bodies in the mucosal staining or whatever it is. So, this particular individual have a particular characteristics. They have this particular sexual characteristics which is like the external genital ears and this particular the male sexual genital ears which is poorly developed. We call them as hypogonadism. The testicles are really small, and having this particular small testicles, they do not produce enough sperm. We call them as agiospermia, which leads to infertility. The individual which is suffering, they have this female characteristic pattern because they have the X chromosome with the female-like substance. They have this particular gynecomastia, male person with the breast, we call them as gynecomastia. We have the current kind of increased amount this estrogen progesterone. So, to this particular persons, they have this particular reduced hairs in the bodies, pubic hairs which is less, and they have these arms and the legs which is little bit longer, looks like this. So, this is a tall person, usually these particular person are, and they have the long arms and the long legs, and with this particular sexual characteristics which is like a female like sexual characteristic look they have with these reduced or kind of absent testicles. So this particular persons, they are phenotypically looking like this, and causes non-disjunction of the chromosomes, which is or mosaicism, they are coming into it. Now, coming to the point, which is mosaicism. What is a mosaicism? Now, what you know so far, we have this particular set of the chromosome which is fixed to a species. We call them as 2n number or 1n number. So, this particular gametes, we have n, or this somatic cells, they have 2n. Each and every cell is 2n. Now, imagine a person, they have some cells with the 2n numbers in the somatic cells. Imagine a person who has this 2n number present. They also have a 3n number present. They also have an n number chromosome present. So, you just like take samples from liver, you get some cells which is 2n number, some cells which is 3n, some cells which is only n. That means the cell line is not following this pattern which it should be following. So, normally if you take the cells, somatic cells from an individual anywhere in the body, it should be having 2n, which should be the normal. But if it is not like only 2n to the somatic cells, it could be n or kind of 3n, these kind of things, we call them as mosaic individual. So, the cell lines which is not fixed, and they have the different cell line. So, some of these things which is normal 2n, some of the chromosome maybe have a loss of the chromosome number which is n, or some of them have got 3n. So, what happens to this particular individual and why this kind of thing happens? We have a disease or which has leading to this particular problem, we call them as non-disjunction. So, what happens over here, the zygote which is developed in here, so developed from this 1 to n numbers to this particular offsprings, which is this one, which is getting into it. So, this is a normal division which is taking place from one zygote, getting 1 to and eventually from 1 to 2. Now, what happens after this, this chromosomal separation, if it is going error after a while, that can lead to this particular normal n formation, one cell line which is coming from here to n, which is getting into 2n. But what happens to this particular region if you have a non-disjunction or abnormal separation of the chromosome taking place in this cell line, this particular cell which is giving rise to one cell which is 3n, other one which is 1. So, this particular chromosome, when it is dividing, separating, they are transmitted to one set which is 3 chromosome number and other one which is 1 chromosome number, and eventually we get this particular chromosomes which is present in the cell line 2n, 3n, 1n. So, if this kind of error of this non-disjunctions or chromosomal separation error happens, we get a cell line which is developing from a single zygote, getting into 3n, 2n and 1n numbers of the chromosome cell lines. We call this as a mosaicism. So, Down syndrome could be of mosaicism error, non-disjunction of this. Some of the chromosomes may be with a normal chromosome number 2n, some of the chromosome may be 21 extra pair, some of them may be just like one less number. So, that can lead to this particular error which is known as mosaicism. Same thing with this happening with this particular Turner syndrome as well. So, this particular non-disjunction error which may be involving the Down syndrome and this particular Turner syndrome is happening there. So, in short, we should have a normal thing, all the somatic cells, it is 2n number. But if you get a cell line of the same somatic cells, some of them 2n which is normal, some of them is excess 3n, some of them is n. That means we have that mix of the cell lines which is happening in a disease, we call them as mosaicism. So, this is mosaicism. And this particular thing happening from a single zygote. So, same zygote, splitting error, getting to disease like this. Now, if we have an other thing happening here, instead of this single zygote, if you have a fusion of zygotes. So, what I am saying, we are getting this particular from one zygote and this abnormal cell line. We are getting the same abnormal cell line in an individual where you have a fusion of the zygotes. And if it is happening, we call them as chimerism. So, this particular chimerism happens here. We have the more cell line which is n number, 2n number, 3n number, 4n number, whatever the number it is, abnormal cell lines are there. But this particular abnormal cell line, if it is produced from different zygotes. That means one zygote was there, then appears second zygote, which is fertilized, which is fused and giving rise to a single zygote eventually, and dividing and splitting and giving a bizarre number of chromosome numbers. An individual is grown, then we call them as chimerism. So this kind of error normally happens? No, it normally doesn't happen. It happens in case of this particular phenomenon, we call them as double fertilization. So an individual, a couple is suffering from infertility. We are treating the infertility. We are giving the drug to increase the rate of ovulation. And with the drug, instead of one ovum which is expelled out, it expels two. So that happens in case of the in vitro fertilization. When you have this extra ovum available, which is fertilized by the two different sperms, and that particular ovum, if it is fused and giving rise to a single zygote, that can lead to this particular problem, which is known as chimerism. So two different zygotes giving rise to different cell lines, we call them as chimerism. If it is happening with a single zygote, we call them as mosaicism. So the basic thing, you have to just figure out where is the difference between the mosaicism and the chimerism. So what is the problem? Cell lines which could be bizarre, N, 2N, 3N, 4N, mix of things. That's constant for mosaic and as well as this chimera people. The difference is, one is derived of single zygote, other is two zygote fusion. So two of them fusing, giving rise to this particular different cell line, chimerism. If it is single zygote giving rise to this, we call them as mosaicism. Mosaicism is more commoner variety than that of this chimerism. And last not by the list, which is the thing which we talk about, is this process, non-disjunction. So normally the chromosome should split, centromere should split, move away and go away to different poles during the cell division. If you have an error of the split, then we have this particular movement of this chromosome is not taking place to the right way. So this thing we call them as failure of separations of the chromosome during mitosis or meiosis. We call them as non-disjunctions. So normal division takes place within this, where this particular chromosome separation taking place and the chromosome moving to the other ends, giving rise to this particular thing which is normal to end. And if you have this particular thing which is known as non-disjunction, which is taking place, then we have this error of the chromosome movement. The chromosomes, some chromosomes have moved and some chromosomes have moved to other poles. So we have this particular abnormal chromosome number yielding out of this particular problem. So this is the normal thing which is happening. And then if you have this particular problem, which is the non-disjunction, separation is incomplete. Maybe this everything is moving to the one side of the cells, other one is going empty like this. Or maybe just like we have this particular abnormal thing that we talked about, chimerism or this particular thing. Now why this particular thing happens, non-disjunctions? It is associated with increased maternal age. So as the age of the mother goes high, the abnormal separation is also quite high. We have this particular gap between this ovulation and fertilizations. We take 72 hours to just like have this particular ovum to live, be potent. So if this ovum is expelled 3 days back and if it is fertilized today, there are chances of this particular non-disjunction is more because the ovum is exhausted by this time with the nutrients. So this particular separation process may be just like halted because of the lack of power or lack of these ATPs. This could be one of the reasons. Exposure to the chemicals, exposure to this particular harmful rays that can lead to this particular non-disjunction. And some families, as I am mentioning, genetic diseases runs in families. Some families are prone to have this kind of error. So this is about non-disjunction that you have to know. Summarily, what you have done today, chromosomal aberrations, mosaicism and chimerism, that's what you have to know, difference between that, chimera, who is chimeras, and who are these mosaics, and non-disjunction and reason for non-disjunction, and fate of the non-disjunction, which is the abnormal cellular divisions and abnormal chromosomal divisions amongst the cells. So this is all for the day. Thank you very much.